Yes, good evening, guys. My name is Evody Nelson, popularly known as the MedLab Scientist. Today, I'm at CBTH, University of British Hospital, and I'll be doing something very different today. So I'll be going around the labs to meet some medical lab scientists intern to ask them some clinical questions to see how good these guys are and also for you to learn from it. Now, follow me. Hello. Hello. How are you, Mr. Kenwa? Okay, this is Manuel Kenwa. And Manuel Kenwa, we'll be asking you some specific clinical questions this evening. Okay. Please just answer us sincerely and then so that people, our viewers, can actually learn from this. Now, what is the anticoagulants found in blood bag?
Okay. When we talk about blood bag, actually, and the storage of red blood cells and blood products, there are different kind of anticoagulants. As dating as far back as 1865, we have had different kind of anticoagulants used to stop blood, but for quality control and to improve the shelf life of red blood cells, a whole lot of improvements in medical science have been introduced. So currently we use the CPDA one to store blood. It's actually the main anticoagulant in blood bag as of today in UBTH. And the CPDA one is basically a component of citrate, phosphate, dextrose, and adenine. Now, the reason why it was included was that it increases the shelf life of these red cells. Because previously we were using CPD, which was only citrate, phosphate, and dextrose. And the citrate being the one that inhibits the clotting factors, it chelates calcium and inhibits the clotting factors, which actually helps increase the shelf life of the red cells and the blood components from allowing it to coagulate. And the phosphate, which was the buffer, which maintains the pH level of the blood, and the dextrose, which actually supplies the energy to the red cells over time. So, but the introduction of adenine to the anticoagulant is actually what introduces the ATP, because it was noticed that over time, when after a space of 21 days, if there is any transfusion to patients, we can now see that most of the times the red cells are not viable enough because of the reduction in the 2,3 TPG dehydrogenase. So, which now led to the introduction of adenine. But we also have what we call SAGM, which means saline, adenine, glucose, and mannitol. But that one actually we use it for blood bags that we store for commercial purposes, because that one increases the shelf life of, instead of 35 days, we now have 46 days.
Interesting. I think Mr. Ikenwa really knows his stuff. Okay, Mr. Ikenwa, I have another question for you here. And the question is this. If a patient wants to do a blood culture test, an electrolyte assay, and full blood counts, what do you think is the order of draw?
Okay.
Correct order of draw for that assay.
Okay. Well, first of all, when you are engaged with the patient that has the request for these samples, you actually first of all, you have to put into consideration your sample collection containers, which would include your plain bottles that does not have any anticoagulants inside it. because the anticoagulants might actually influence the test, which in this case we are doing a blood culture. Then we also look at using a lithium heparin bottle and an EDTA container.
That's what you mean. Another withdrawal is the blood culture first, the lithium heparin, and then the EDTA. Thank you very much, Mr. Kenwa. I think I enlightened no much with you. Hope to see you in other videos.
All right.
Thank you, guys. Now, we'll be moving to microbiology lab to meet some incredible interns there who are also good. Well, let's see how good they are this evening. We'll be asking them some clinical questions also. Now, follow me. Let's go. All right. Good evening, Christiana. How are you doing?
I'm fine.
Can you see my camera?
Okay.
Okay. So, Christiana, we have some questions for you this evening. I think you are one major.
Medical microbiology.
Sorry, medical microbiologist. You're got of them all. Okay. Christiana, now I'm asking you this question. What is the causing agent of cholera and what medium can it be isolated?
The causative agent of cholera is Vibrio cholerae, and the selective medium for Vibrio cholerae is TCVS. The formula of TCVS is thiosulfate citrate bisulfite.
See this get most at score. Now, second question. Can you list 3 possible organisms that can be isolated from cerebrospinal fluid of a patient with bacterial meningitis?
Okay. Bacterial meningitis can be caused by 3 different bacteria, and they are serial meningitis, Streptococcus pneumoniae, Haemophilus influenzae.
Please, can you recap on the audible? Let my audience hear it.
Okay. Bacterial meningitis can be caused by 3 different bacteria, and they are serial meningitis, Streptococcus pneumoniae, and Haemophilus influenzae.
All right. Thank you very much. Now, let's move to the next. Who do we have here?
Okay.
Good evening. How are you, Mr. Only Precious?
Really?
This is one of my colleagues also, and we're asking him some specific questions to regard histopathology. I think what major are you again?
Histopathology.
Histopathology. That's very good. Now, Only Precious.
Yeah.
You see, we hear people often say, take session to water, take session to water. I don't know what it means. Why you to carry session and take it and put it inside a bowl of water? I don't understand. Right? Please tell us what it means to take session to water.
Okay. Taking session to water. This you do wax in xylene. You do wax in xylene, then you hydrate in a same degree of alcohol, which is 100 to 90 to 80 to 70 to 50. Then you rinse in water. The process of taking session to water is if it's 90, if it's 100, if it's 100, the water is 0 there. But we are taking the session to water. If you take it to 90, the water will be 10%. The remaining percent will be 10. You are taking it to 70, water will now be 30. You are taking it to 50, water will now be 54. You now take it directly to before you now rinse it in water. So that's the meaning of taking session to water.
Mr. Only Precious.
Yes.
Now, I want to understand something. Why is it that you don't just take this session, as you say, and put it inside water? Why does it have to pass through different grades of alcohol?
In order not to distort the tissue. Do you understand what I'm trying to say? Like during Amatom period now, you want to take your leg now, you just enter like that. You don't walk your leg to check now.
I think I'm like,
so that not to distort the tissue, more for the job of the tissue.
okay.
Yes.
So taking directly to water, we just distort it. So not to pass it through that grade.
Grades of alcohol.
That means it must respect that others.
Yes, the same degree of alcohol.
Thank you very much. Very understood.
All right.
Thank you, any pressure. Now, we're going to chemistry, ask some clinical chemistry questions to some of our interns there. Now, follow me. All right. Good evening, Mr. Emmanuel Pekina. So, we've been going around the labs. We've been to hematology, we've been to microbiology. We've had different specialists about some different questions.
Okay.
Yeah, so, right about now, we're in chemistry lab. And we are here to ask you some clinical questions. And we'll need your response towards these questions.
Okay.
Are you with us?
Yeah.
Okay, now, in a patient with tuberculosis meningitis, what would you expect the CSF glucose and protein levels to be?
Okay, for tuberculosis meningitis, we are dealing with bacterial type of meningitis here. So the CSF glucose would be reduced, while the CSF protein will be elevated.
Why is it so? We'd like to know.
Since we are dealing with bacterial meningitis, this tuberculosis meningitis, the mycobacterium tuberculosis is likely to feed on the glucose present in the CSF, while causing reduction in level of CSF glucose. But the bacteria is also having some glycoproteins on its surface, and also during tuberculosis meningitis, there are production of immunoglobulins, which can lead to elevated CSF protein levels.
I think this guy is doing stuff and he has actually said a lot. I have some other questions for you. Yeah, please. My next question is, using a clinical terms,
Okay.
tell us why or what might happen when a sample for electrolytes is mistakenly collected into an EDTA container. That means I collected a sample for electrolyte, I put it there an EDTA. What will happen? Is it normal or can we use it like that?
No. We don't use EDTA for electrolytes for a reason. Using EDTA may cause what we call pseudo hyperkalemia. That's first increase in potassium. And it may also lead to what we call pseudo hypocalcemia. We already know that EDTA chelates calcium. So there will be firstly reduced calcium levels and firstly increased potassium level, which we call pseudo hyperkalemia and pseudo hypocalcemia.
Yeah, you have actually said a lot. Pseudo hyperkalemia, pseudo hypokalemia. It is okay. Let's proceed. Now, the next question here is, a patient having a decreased total T4, total T3, and total T4 and elevated TSH. Identify the thyroid disorder of these patients. How do we identify it?
Reduce total T3.
Yes.
Reduce what again?
It's a decreased total T4,
Okay.
total T3,
Okay.
and T4,
Okay.
and elevated TSH.
Okay. Where we are having elevated TSH and reduced thyroid hormones, we'll be looking at primary hypothyroidism, because in endocrinology, especially in thyroid function tests, is what we call the hypothalamic pituitary thyroidal mechanism. Okay, so for thyroid hormones to be low, definitely there will be a feedback mechanism to the hypothalamus to release thyrotropin releasing hormone, which will now stimulate the anterior pituitary gland to release thyroid stimulating hormone. Now, the release of thyroid stimulating hormone ought to stimulate the thyroid gland to begin to produce thyroid hormones. Now, TSH is elevated, but the thyroid hormones are still low. It means there's a problem with the thyroid gland. So, in that case, it's primary hypothyroidism. But outside normal thyroid function test, we could also assay for thyroid antibodies like thyroid peroxidase, thyroid globulin autoantibodies to rule out or to indicate the presence or absence of what we call Hashimoto's thyroiditis, which is autoimmune. So those are stuffs that can also cause hypothyroidism. But what the clinical significance here is primary hypothyroidism. Yes.
Mr. Emmanuel,
Thank you.
this guy is really tough.
Thank you.
I believe you will agree with me, even the cameraman, that this guy has actually said a lot.
Thank you.
It's tough. Thank you for joining in this segment. And again, please can you tell us your name again?
Okay, my name is MLS Emmanuel Afekena.
Thank you very much. Okay, right about now, you see, we've gone through many of these labs. We've seen many W scientists, interns, and you see how good these guys are. So I want you to rep your department. If you're in hematology, rep your department. If you're in medical micro, rep your department. In chemistry, rep your department. If you're in histopathology, rep your department on this comment section and give us a thumbs up and appreciate these guys. They really did well. Thank you very much. I'll see you guys on other episodes. Bye.